Good afternoon, everyone. I'm Shazia Shabir, your moderator for today's session. On behalf of Neuroptic, I would like to wish you all a very warm welcome in today's webinar. The topic for today's webinar is Systematic Basic Clinical Approach in CVI Management. Cortical visual impairment is not just an eye problem alone, it is a brain-based visual condition, and this makes assessment and management very different from routine optometry cases. Through today's discussion, students will learn how to approach a child with suspected CVI in a structured and systemic way, starting from history taking, clinical observation, functional visual assessment, and moving toward appropriate management strategies. To guide us through this topic, we have a very well known name in optometry, Dr. Rupali, a clinician known for her depth of knowledge, clarity of thinking, and commitment to advancing optometry practice. She's a consultant optometrist at Safe Sight Center in Pediatric and Binocular Vision Department. She not only holds a bachelor's and in optometry, but also a fellowship in optometry. She's a certified FTP in CVI and Seizure Care Perkins, USA. But best of all, she's an amazing clinician and even better teacher. So without further ado, let's begin the session. Ma'am, the virtual stage is all yours.
Hi, am I audible?
Yes, ma'am.
Thanks, Shazia, for warm welcome and nice introduction. So, hoping everybody's wake up. So, this session is going to be very interesting if you all and each one is going to participate in this session because this is the topic which I like to talk about. But even I can do much more, whatever you are thinking about. This is not related to your clinical part only, but for this, you required hard work, dedication, and passion too. So I'm going to share my PPTs. In between, if anybody have any doubt, any query, please do your QA in QA session. You can drop your questions also.
Yes, ma'am.
I will wait for a few more minutes.
No, ma'am, you can start.
Okay, fine. Am I audible? No, my voice is clear.
Yes, ma'am, everything is clear. Your video is also quite all right, and your audio is also quite all right.
Okay, let's start the session. Systemic, basic, and clinical approach in CVI management. So, what will be the object today for the discussion as well as the presentation also? So, as we all understand, there is a CVI, which is cerebral visual impairment, as we known as some of them are saying cortical vision impairment. So, these both are almost same, but what happened to the cortical vision? As we can understand, there are few margins of brain which is infected in cortical vision impairment, but in cerebral we can understand cerebral is a part where brain is also damaged, and your cerebellum part which is responsible for motor and movement, it's also damaged, so we call it cerebral visual impairment. So first of all, we need to understand whether it is acquired or congenital, whether it is present by the time of birth or it is acquired due to some secondary complications or disease also. So what is going to from this session, what you people are going to get benefit, does not matter you required any special, the certification to dealing with the CVI child. You don't require any special identification. Okay, fine, you don't have any certification, you cannot deal with the CVI child. So first of all, what you need a good compassion and the understanding how you need to deal with the CVI child, because anybody come up to you, you don't know the history about the child, how you can say CVI, it's a CVI, so we need, full of attention. So we are going to discuss about the power of detailed clinical history and the communication play skills a vital role in CVI assessment, because this is going to give you a lot of clue how you can get to identify, okay, this child may have cerebral visual impairment. So first of all, you need to be become a very patient listener when you are dealing with the child or a patient, any of the patient. So in CVI, first of all, if we are going to ask about the history, then we need to ask, okay, fine, what type of problem they are having, because they are not going to come you with the complaint watering, itching, and yes, definitely some of the time with the watering and itching complaints also. So now what you can see, because when you are going to deal with any patient, so you need to ask first what type of problem they are having, because in CVI patient few people are very understanding and literate, so they can understand, okay, fine, my child is having CVI, CVI because earlier it's diagnosed. But some of the time what happens, you are dealing with the normal patient, and when you are dragging down to your history point, okay, what about the birth history? Is he normal child, preterm child? What about the delivery history? It's cesarean, it's normal. Then you are going to ask few specific points, whether your child was having any high fever, whether your child was having any history of seizure. Then you get to know, okay, fine, there is a some part of affection in the brain also. So engaging the patient is an art. First of all, whenever you are dealing with the patient, you have to sit down with the patient and make a eye contact. So that is going to boost confidence and the communication become very strong between you and your patient also. We relatable story. Suppose that patient is very tired and very upset with, moving here and there with so many consultation already has been done. So how you are going to take their attention as well as their attentiveness also. Encourage question and provide thoughtful responses. Whatever he's saying, he or she is saying, you have to listen empathetic. And then empathetic approach is very important in dealing with any kind of neurological patient. Similar case discussion gain confidence of a patient. Suppose you are telling them a positive story, okay, similarly the similar case I have seen 4 days before also, one month back, and they get good outcome. Then it is going to boost your confidence as well as patient is going to know a lot about their child. So in CVI we are calling it as umbrella, purely working because CVI is not only brain, because your eyes and brain signals are there, but your brain is not able to process, okay, what it is, where it is. Then we have to understand what happened, when happened, and how it's happened. Because in my previous slide also I told you that some of the time CVI is congenital, but some of the time it can be acquired also. So in this umbrella, if we can see, there is a lot of things which comes across: loss of visual acuity, visual field defect and inattention, poor contrast sensitivity, oculomotor issues, visual agnosis, motion perception difficulty, visual spatial difficulty, and visual inattention. I know these all are seems, some of you understand ये तो बहुत ही high five words हैं, but it's not like that. When you are going to deal with the patient, you have to, notice each and every single movement in CVI children. So suppose if any CVI is coming to you, they are not looking like a normal child. Some of them are like looks like a normal child. How you can identify, okay, fine, this child may have CVI. So these are the crisp and the precise point you need to look for. So first of all, you need to ask about birth related complication. Like if your child immediately cried after birth, not, then what is the problem with your child? Immediate after birth, few seconds after birth, or an hour about a birth. Then lack of oxygen is causing hypoxic injuries in brains. So that is why one reason can be the crisp and clear from your history part only, the lack of oxygen. Okay, fine, then you can understand, okay, this point is going to favor in of CVI. Then HI, you can understand, okay, fine, hypoxic ischemic encephalopathy. Suppose they are come up with the prior consultation reports and they are anywhere not mentioned this child is CVI. If you see this kind of terms, okay, then there is a question, okay, fine, this can be also a part of CVI. Intraventricular hemorrhages happen because of some of the time brain injuries. Child is not able to immediate going to intake the milk, not immediate going to underpass the oxygen also. So hypoglycemic injury also some of the time happens with the child, those who are preterm and those who are kept in NICU also. So brain injury is also going to cause CVI and affect your brain also and some further parts of your brain. So TBI is traumatic brain injury. Trauma can happen any of the thing because I've seen many cases. So they are not the congenital CVI, they are acquired CVI also. Acquired CVI means what happens? मम्मा ने उसको गोद में लिया and suddenly baby fall down from the lap. So the brain damage and the brain things happen. And stroke, some of the time stroke happens in earlier ages also. It may be because of hypoglycemia, hypocalcemia and hypoxia also. And some of the time few tumors are present into a brain during the time of birth also due to some medications, drugs and anything. It can be anything because we cannot perceive anything before the birth. And infection also, some of the time meningitis and encephalitis is infection which child may having. Even if parents is coming to you, then you can ask history, so they are saying okay, my child was having meningitis, so they kept in NICU for the observation, and these antibiotics and steroids given. And one more thing, there are one syndrome also, nephrotic syndrome, which we find more in CVI children's also, in normal kids also. So we need to specify the history, okay fine, because in nephrotic syndrome they are going to give some sort of steroid as well as antibiotics also, so it's may causing some another injuries to the brain and some severe infections also. So developmental issues also we need to understand. Some of the time structure brain anomaly is also there, because some of the time what happens, child may have microcephaly also. So microcephaly, when if you see the child's small head size can be there, and hydrocephaly if the child head will be like this big, because hydrocephalus is a condition where fluid gets stored into the brain. For that we need to do some neuro intervention, some surgeries also to prevent the hydrocephalus thing, because those who are having hydrocephalus, there are more prone and have to tendency seizures also in the children's. And delayed visual maturation, because brain is not working fine, so they are not able to confirm visually okay what type of object is there. Even some of the time they are not responding to the light also. So this is a very important table, which is call it as Hyatt classification, which everybody should understand this, how we are going to judge our visual behavior only that this child may have CVI also. If you are going to see any child, if child is 6 month old or 3 months old, then you are going to show some light. First, we being as an optometrist, we are going to understand that we are going to see first fixation and following things in the babies. So if there is a no perception of light, suppose you are light but child is not responding, even not looking from where light is coming, so what you can think, okay fine, this child may have also a CVI problem. But with CVI also, child may perceive some amount of light also. It depends on what part and which area is damaged in child brain, because our occipital is responsible for vision, contrast, and visual field. If you see in MRI report and there is a occipital lobe involvement, then if child is not responding for light, color, contrast, and visual field, you can correlate your things, okay fine, because there is a damage in particular lobe and area of the vision which is responsible for these things, where there are no perception of light. But we need to work forward on that, we are going to discuss it further. Occasional fixation on large object, faces, or movement in the environment. So suppose if you are going to see your child when you are examining, so if you are showing them small object, they are not going to give you a high-fi preference over the object. When you are showing them large and bright object, because red and bright object everybody can perceive because of the higher wavelength and some element of physics also. So the child is able to recognize, then you can mention that okay, child is not able to look at the small object, but child is able to recognize over the large object. Then you can mention accordingly. Then variable function but movements of good visual fixation indicate by the ability to see small objects reliably fixate on faces. Some of the time parents come up with the complaint also, my child is 8 month but my child is not able to look at my face, he is able to recognize my voice only, because there is a no perception of light. Then how you can understand that child is able to look over the face also? There is a reason behind that. Maybe the refractive error, maybe there is a brain injury, maybe there is any the field defect. But how you can judge, because the parents also don't have any history and you are not also paying that much attention to collect the history part and to rule out okay what type of thing. So that is why we need to open your eyes and widen your eyes when we are dealing with the pediatric population, because it's not only I am going to save a blindness, but you are going to eradicate blindness, because when the child is going to grow up and suppose you skip that part, but that child may have only amblyopia, only refractive error, not the CBI. Because agar you left that part, then you feel guilty, okay fine, because of me, and that same child come to you after 6 years and that child is amblyopic, then you feel regret and so much of guilt, why I am not able to treat this child. So whenever we are dealing with the patient, we have to be very attentive. then you can become a good clinician as well as good doctor to your patient. With one or both eye opens, if we see the if these 3 points we passes on, so we have different type of chart, the teller equity card and the lia paddles also. Then where we can identify, okay, some of the time when we are occlude one eye, child is able to resist for the same when we are doing for the other eye, he is resisting or she is resisting for the same. Then what we can do, we can check the binocular vision. If there is a 20 by 400 vision, that means okay, child is able to see some amount of, because from the very variable distance we can see. Suppose when we, if this is a patient and we are placing the paddles here and not able to recognize, then moving, we can moving little forward also. And suppose if they are able to see it from this distance, then we can move forward too. Then we can identify, okay fine, this particular distance child is able to see the contrast and the image whatever, because on lia paddle and tag also there is a black and white gratings lines, so that how they can presentation not visible. Sarja, is my presentation is not visible?
No, no, it's visible. Munasha, I think there seems to be a network issue at your end. So recheck it or rejoin. Ma'am, you can continue.
Okay, then with one or both eye opens between, the vision should be, we are considering the optometric vision is to 20 by 50 and 20 by 20, but when it's reversing, normal sensory and visual stimulation is there, then you got to know, okay fine, my CVI child improve. So this table you can use, you can use as a diagnostic as well as therapeutic things also. This being into diagnostic tool, this is going to help if you are passing, if you are doing a rehabilitation part in these kind of child, then you get to know, okay fine, we passed this first stage, second stage, then you get to know, okay fine, my child is improving. But if you are seeing it diagnostic purpose, then you can get to know, okay, level 1 perception is improved in my child present or not, level second is present or not. That's how you can identify between the diagnostic and the your clinical visual correlation also. So common sign and symptoms we see around our CVI child, if suppose they are 1 or 2 years old. So literally few of them are coming up like this. They are not even able to see the up things also. So we have to see visual attention also and visual perception also. Some of the time you are showing most attentive toys, red color, black color, vibrant, but they are not attentive at all. But if you are playing some sound, they start looking like this here and there. That means they are not following the object, but they are attentive for the sound. Then during the time of your therapy you can sound as a clue. But if that child is preferring all the time sounds, that child may dependent on the sound. That means audio sensory become very strong for that child, but visual that child is not able to use it, because it audio is easy thing for them, because the audio is coming and the child is try to locate, okay fine, the audio is coming from this side or that side. So some of the time we feel like, okay fine, child may have some amount of vision, but visual, if we're talking about visual, so there is no any visual response from the child. Then we have to see visual preference also, what type of visual preference the child have, whether they are looking at the simple target, simple preference we are going to provide, if they are they are not responding for the same. So I have a similar torch whatever we all are using in OPD. So over the torch I putting a red paper also, glossy paper. When I am throwing the light through that torch, then child is able to recognize some of the time, because a red color our brain is able to sense naturally as compared to all colors. Then recognition of object also, some of the time what happens even in infants also as well as toddler also, if you are showing pictures of family members, then they are able to understand, okay, this is masi, this is bua and everybody. Why I am taking this example, because this you all can feel, because I am not going to put so hi-fi example. So how we can do, if the bua is coming in front of child in picture, that child is able to recognize, but in front of that bua, dadi, anybody, he is not able to recognize. That means he is not able to recognize these familiar objects, because brain is not giving that much command, okay fine, quick response is not there, because there is a defect in brain. So child is able to perceive, okay fine, object there, but 5 minutes later identification become a problem. So that's how we see, okay, fine, child is having problem with the recognition object at different places. Then visual motor skills, we also need to understand what happened, because in CVI child, if we are putting, so much of things together, become the object becomes so cluttery, the environment becomes so cluttered for the child. And if you giving them command, okay fine, you have to, take this toy, the child becomes so clumsy, so they become so irritated, what I have to do. But if you are keeping one object and giving them a command, two object, okay fine, you have to take this red one, then child is able to identify, because their brain is not able to understand so much of clutter. Even kai baar kya hota hai, we are at home and our home is like ek saman wahan par, then we also feel very puzzled and irritated. So then how you can are going to understand the child is already having problem, and we can tell them, okay fine, you are going to this, and they are not that easy to command for them also. Visual fatigue also, getting easily overwhelmed with the visual inputs. The same thing, if you are putting so much of stuff, then they are not able to initially identify, okay, what type of object is. Maybe after the rehab they are able to identify, but initial some sort of time they are not able to identify what type of object is. So now we are going to little bit talk about the clinical part also, then how we need to judge, okay fine, how we can do the visual field, visual contrast, visual acuity assessment. And basically, suppose you are not a CVI expert, but vision, refraction, and the attender, everybody is going to attend in everyday OPDs also. So first of all, we need to ask about the detailed clinical history, head to toe, like why they are coming, what type of problem they are having, anything related to their birth history. Birth history, if you are dealing with any pediatric patient, you have to ask birth history, NICU history, any fever, any seizure, preterm delivery, because this is going to give you clue towards your CVI thing. Any seizure, why happened, when happened, and how it happens. You have to keep asking. Then you get to know, okay, fine, these are the crisp point of my. Then refraction is very important, because in CVI they are not very attentive, then how you are going to give them a particular target. But you can perform near retinoscopy also to get a good amount of refraction also. Some of the time if they are having, high plus numbers also, then plus number also is going to, because at till the age of 4 years child is able to see only, their activity area is for near only. So first of all we are going to approaching the near targets, then after we are going to shift the vision slowly. Even these glasses is going to help the child, as well as clinically you're going to prescribe, but in purpose of therapy also, because plus is going to magnify the images. If it is point 0.5 0.25, then you can avoid. But precise medical record and any previous illness, why I am keeping these points, because these are very important. Because if you're any point lefting out, then you are unable to get and grab child is having CVI. CVI can be mild, moderate, severe, and very severe. If anybody have mild CVI, then your these parameter is going to give you clue. That's how you can identify, okay, you may have CVI. And in infants also, why I am taking this slides different and points different, because you all can understand how we can identify, okay fine, if we cannot perform retinoscopy, we cannot check vision, then in infant also how can we see. Because your at the age of 2 months your child is able to identify the horizontal movement of eye, and if you are showing the object, some of the time they are able to see vertical also. But till 6 months horizontal and vertical movements completely develop. If you are showing the torchlight, see, some of the time what happens, patient is come up to you, but you are showing light, okay, child is not fixating, that means uncooperative. No, you have to be very patient. When you are showing light, then you have to see the response, okay, in center child is fixating, then hide the light behind, then show it from temporal side, okay, child is responding with moving head, moving eye. You have to notice both the thing together. If you are showing light, child is able to fixate from here, from there, everywhere. Okay, then you can see visual threat response also. If you get confused, maybe child is not responding, then you can see this. When you are waving your hand in front of eye, so we all have tendency to blink our eye, so we are call it as visual threat response. That means just some amount of visual acuity is there. Minac reflex, when we are throwing the light, child is sleeping at all along, but they are squeezing their eye, so the reflex is present. And some of the time we are calling it as popping reflex also. That means they are doing like this, so we call it popping reflex. For visual field, similarly, there is a few equipments also, but if you don't have any equipments, you can see, you are showing one target, red color. If child is able to fixate temporal side, okay, temporal field is fine. If you are showing the up is fine, but if you are showing down, okay, down is no there. Some of the time this can be optic ataxia also and lower field effect also, then we can correct it with visual prism and all. So that's how, leaving all the paddles, puzzles, and charts, you can identify child is having vision or not. So here, as you can see, this child is 4 month old, and we are doing it at early intervention clinic. But this child is able to recognize for the pom pom. Okay, so this we created from the waste when we are using birthdays and all. So if you can see, child is happily looking at the target. That's how you can identify, okay, fine, there is a vision. And parent, you can make parents also understand, okay, child is not able to recognize your face, but there is a vision in child eye, and we can improve this via therapy, whatever you are going to plan. And here you can see, in dark light also, you can see a bright object. So bright object, you have to hold it like this, and slowly you have to move horizontal to see gazes if he is fixating or not. Suppose 10 time you are moving that target and child is able to fixate over 2 times, that means there is a vision. You cannot say this child is blind, so there is a visual acuity, but we need to improve this. Similarly, when we are working on visual fields also, so we have puppet faces. As you can see, you can draw this by yourself also. If you cannot able to buy this, then you can also, few of the things in CVI assessment, interestingly, you all can made at home also. So visual field is most commonly affected because there is a brain problem also. Because eyes are looking fine, hand is looking fine, some of the time motor part is also affected, but what is between which is going to affect their, because the brain is not able to follow the commands between eye and the hand coordination and eye in the brain coordination. So no, do not use this field in the beginning. Because because your child is not able to recognize that this is a puppet face, then you can understand this is to recognize the puppet face. But yes, due to the higher as per the higher classification in my previous slide, if your child is able to recognize 20 by 400, 20 by 500 also, then you can start showing this puppet face. Work from non-seeing to seeing area, because seeing mein to your child is able to see. Even in fields also, when we are doing confrontation, we are doing non-seeing to seeing area also. Then stimulate the edge of visual field more to expand the seeing area. Then teach scanning to ensure all fields are used. If you see, okay, fine, in CVI child, how you can teach them scanning? Because you can do the stimulation by holding in one hand or two hand together, and slowly down you have to keep the child head keeping the child head low in lap, and teaching them look here, look there, keeping their head up, keeping their head temporal side, basal side, and downside. That's how you are going to tell them scanning also. Functional vision assessment in pediatric age group is very important. Then few of them, if they don't have any vision, then what you can do, tactile sensation to manage visual spatial difficulties. In umbrellas also we learn about the visual spatial difficulty was the one point. How you can see, tactile is a clue. Suppose those they don't have any vision. As per my experience also, I can say, because I'm deal 2, 3, or 4 patients with no perception of light, and right now they are in school, they are doing activities with so much of nystagmus, poor fixation, and the child is now 6 years old. And that was, literally I was feel like cry, that when the child start going school. Because how I start mouse therapy, I remember the time I'm just putting, wet atta, different types of clay, different type of texture. So the, vision rehabilitation, I start with the texture only, because texture is going to give a sense, okay fine, there is a something. Then slowly I started the auditory things also, to give them clue of a sound, okay fine. Then slowly when these two becomes better, then child is start able shifting over, looking over the object. Then we shift over the visual motor skills also, including vision as well as motor perceptions also. Lia mailbox for optic ataxia can start 2D and gradually progress to the 3D. Okay, I don't have Lia mail, but yeah, I'll show you how it is going to help. Um, just give me a moment. So Lia mail, if we understand, so Lia mail is like this. Not able to make it properly, but yeah, something looking like this. So how we can see there is a optic ataxia or not. This is a test where we can identify child is able to do or not. So this we are keeping it like this, and this is we are going to put child hand in toddlers with 3 to 4 years, because they are able to hold it. So if they are able to put it like this nicely, that means there is no optic ataxia, there is no eye hand coordination. And we keep it like different direction also, to see whether child is able to understand or not. Because if you see this part also, this you can made it by yourself also on hard wooden cardboard and anything. Because CVI is a passion, you can do anything to treat them. If they are able to do it like this, that means you are two things you are able to identify, okay, there is no optic ataxia and there is a good eye hand coordination. This is become your therapeutic tool as well as diagnostic also. In diagnostic, how you are going to judge if child is not able to suppose this is a vertical line, but child is able to do it like this, that means we need to train them. We need to train them to understand, okay fine, how we need to work with this. And they are improving slowly, but they are definitely going to give you a positive results also. Children with the dyskinopsia, difficulty in tracking, make sure both child and object of interest are absolutely still during the task. Suppose if you're seeing it over the table, we are keeping one paracetamol bottle and we are just giving the command to child to go and grab it, but child is not able to do. Suppose this is a bottle, we are doing like this, but at fourth time, fifth time, they are able to identify, okay fine, this is something, and they are going to keep it up. But some of the time what happened, truly they not understand what command, they feel irritated, they start yelling, they are not focusing at all. Then also we need to train them nicely and they will understand. So if at home also we identify that, okay, what type of problem they are having, then we can modify the rehabilitation part during the therapy also. Here you can see, because in numbers also you can see there is a pin. So pin is going to make their pincer grasp stronger, and motor and hand coordination also. Even these kind of pegs you can use for your child also, to identify there is a eye hand coordination or not. Because in this cube, if they are able to place it nicely, then there is no eye hand coordination. But if keeping here, keeping there, that means you need to train them. So this is a Leah mail also, you can see here. This is made by a hard plastic, so that we can give it as home therapy also, as well as office based therapy and diagnostic tool also. So if you can see, I'm playing video of this. Child is able to identify, but in this peg, if you can see, there are a lot of peg. We are giving them command, you have to specify this color you need to choose and put over the peg. So if you'll see, they are not able to, एक बार में one go में he is not able to pick the pad. And this also, if you'll see, if you can see, yes, child is able to pick it, but not very nicely. We have to train them. So keep it simple. I am saying this from my beginning of my slide, because clutter is going to confuse them. Clutter is going to overstimulate their brain, and some of the time they become angry also, they become very aggressive also. So that is why at home also people are saying, ma'am, we have one room, two room, but your child still yelling, doing so much of aggression, because they don't like clutter. At a one time their brain is able to perceive only one image. If you are giving two, three, four, five things together, then they are not able to identify what it is, where it is. Then present one item at a time, dark solid background, because make a habit or make a rule, whenever we are going to do things for them at clinic, at home, at anywhere, during the time of therapy also, use darker color, primary colors only, red, blue, yellow, either red or orange, and black and white. So they are going to make these colors simpler, as well as they are going to add so much of color to them. Two colors, three colors, then four colors. But from the beginning, if you are showing which is red, which is blue, they are going to confuse. Develop a routine, way to present item, complete task, same routine to be used by the caregivers also. Because this become your treatment part. Increase complexity slowly over the time. As I told, at a time you have to give one thing also, then they are able to identify, then keep one here, one there, then ask them, okay fine, now you have to choose apple, now you have to choose tomato, whatever you are keeping there. They have to, then their brain slowly also understand. Because brain is what, if there is a 80% damage in brain but 20% is residual part, you have to keep that 20% part is positive way, and you have to work over this. If you left, yeah, 80% is damage, how I can going to help this child? No, take it 20% as positive also, then you can start working with them, and trust me, they are improved with the time. Using movement as a tool, as this picture, if you can see, at a time we are keeping one child during the therapy also. So use movement to initiate looking at the distance, as I told you during the Leah paddle thing also. First slowly you have to keep it close, then your child is able to identify from here, then you can slowly gradually increase the distance of the target. Use to engage learning, improves attention of span also. Suppose if you are teaching somebody also, then you are keeping things like एक दिन में एक चीज पढ़ाई, then you are able to identify, okay, if there is 50 students in your class, then out of 50 how many of them understand easily, then you can keep your practice like this. Even these children also, we really need to work hard. The patience need, empathy need, everything. Because हो सकता है कि 1 month या 2 months are not going to get any improvement, but slowly with the time definitely they are going to improve. With you also, your their patience, patience also, they need to very empathetic, and the patience also. If they are like "Ki, I am spending money, I am spending time, child is not improving," then this is a waste of time. You need to counsel them accordingly. Because what happens if you are moving here and there, South Delhi, North Delhi, East Delhi, there are so many therapy center, because this has become business now for the people also. Then they are keeping just 30 minutes of time for the therapy only. After that they're saying, okay fine, you have to do it at home. You are not following the same thing, then how you are expecting us to improve the vision of a child? Then you need to put hard and make your things very clear, what you have to do. To do list also at home also, patient need to give, parents also need to understand, parents also need to perform. Because we are 20% only. If we are dealing these kind of population, 80% parts parents also need to perform with the same. Use a screen to cut out any other ongoing activity in the room. So suppose if you are taking four children together, so there should be partition in the room. At a time you cannot, make foot children to sit together, because one may have behavioral problem, one may have or some autistic feature also, one may is having some deafness problem also, so you have to treat them separately at one child. So here if you can see, if we are going to check response of the child, you can see. So this is not necessary child is going to give you response all the time. In all cases we have to track the targets and the objects, and to see where is the best fixation for the child, then we will deal accordingly. So as you can see, the side gaze child is able to look, in good way. For this side also, Slowly, when we are doing for the down gaze, child is not that much attentive and not giving that much response. But for the horizontal gazes, child is able to recognize, okay, fine, there is a object. Then here, multisensory approach is there. Stimulate sound, touch, and vision together. Here you can see she's a ma'am. Ma'am is using a un wala toy to just give the child to the sensory stimulation, touch and feel. Okay, fine, this is something. Some of the time, what happens? आप लोगों ने देखा भी होगा when we are giving, soft toys, child may become so irritated, डर जाते हैं, okay, fine, मैं लाइट ले रब कर देती हूँ. We are squeezing them, तो बहुत then we have to understand their behavior also. Then optimal stimulus, correct stimulus at correct frequency, correct intensity. Frequency intensity means that means you have to give it, see. No, you have to see. Okay, fine. Slowly you have to move. Slowly you have to move. If there is a good vision, then you can slowly increase your intensity of showing the objects. Correct duration. It's not like that कि आप 1 घंटे therapy कर रहे हो तो वो ज़्यादा improve हो जाएगा. But correct duration. If you are giving 20 minutes, 20 minutes should be fruitful. Correct environment also. If there is so much of clutter and noise and you're dealing with these kids, they are not going to give you any of response. Give frequent visual breaks also. Suppose 10 minutes session has been done, then give 2-3 minutes break, then introduce the same object. That's how you can do it. Refrain from visual task when child is hungry. Some child start crying, small babies. Some of the time during the therapy also we need to take them in lap also. Then we need to give them break, as well as the mother also. Visual stimulation therapy. Suppose in this child you can see we are showing red target, but child is looking at down gaze. Then we have to see, okay, fine, child is looking over the target or not. But we have to keep showing the targets. 1 day, 2 days. हो सकता है कि on fifth day child is able to recognize and identify the object from the closer distance. Reaction of child. Each stimulus needs to be observed. Make adjustment to further engage the child for refine visual stimulation. Some of the time what we are doing, we are using the glossy sheet also because there is some sparkly part. So with that we are showing torchlight with the tiny reflex. Child is also able to see, because these you can keep in your pocket also to check there is a visual things present or not. Then general principle of early intervention is a part of CVI. We need to do it. Then how we are going to do it? Functionally of the other things is also work in the visual field or word of the child. Communication distance, from what distance you are going to communicate with your child. Visual field, trust, movement, friendly, avoid moving objects. Attention span also we need to check child is attentive or not. Parent centered approach, posture is a vital importance. Use therapies that can replicated at home also. Then parent and caregiver education is a most important part in this kids. Education and training to the parents and caregiver, its impact on development also. Strategies for supporting their child's visual and overall development. Suppose child is not able to sit, they are like this, then you can tell them some posture therapy also had at home, because I am teaching them corner sittings, sitting with support, sitting with pillows. This everything, how they need to feed the child also, I need to teach them. Fatigue, if they are having fatigue, any medications, basic conditions. If child is having seizure, then they are on medications. So the seizure medication may going to affect child sleep also, so they feel clumsy, drowsy and sleepy most of the time. So you have to see the time. Even we are going to ask during the time of therapy also, what time your child is active, what child your child is sleeping. Then we can identify, okay, this time is suitable to identify the child. Early intervention is important part. Then reassess and rediscuss. Suppose they are from far away and you are giving some sort of therapy, some recommendation, and they are come up with the nothing they are following. Then how you need to rediscuss and reinforce also. You need to doing this, you need to do, because they become so tired going here and there, because any CVI child is having seizure problem, hydrocephalus problem, they have to do multiple visits to the neurologist. and neurologist is going to give so many medications also, they have to go and do. So you need to be very empathetic. Even some of the time वो ऐसा भी बोलेंगे, why I have to waste money, my child is not improving, then you have to be patient. Okay sir, this is going to happen, but he or she will improve definitely. So here you can see, this is a very important part of your home also. Environmental and home modification is a, part of CVI practice. Suppose you are doing so much for the child, but at home there is nothing, call it as, therapeutic thing. Home is cluttery. मम्मी इज लाइक सपोज अगर हम पुराने जमाने की बात करें तो हमारी मम्मियाँ बिंदी लगाती थी, सिंदूर लगाती थी, काजल, डार्क लिपस्टिक. सो एंड सपोज दिस इज अ बेबी, so they are keeping baby like this. Okay, so baby like this and doing this, so this is also giving, a visual stimulation to the child, because they are able to identify the red bindi, red sindoor and contrast. And हम लोगों को भी याद होगा जब हमारी मम्मियाँ पायल पहन के आती थी, तो हम लोग पहचान जाते थे पायल की आवाज से कि वो मम्मी है. So it's a sound clue for the child, chudi and all. So this is, not even in CVI children's, we are keeping the parents saying you have to wear red t-shirt, you have to put red bindi, you have to do malish at home. So child can, get identify, okay fine, she is my mummy, she is my father. Even in picture also, if you can see यहाँ पर, and here you can see the difference, the contrast become very better. In last third picture you can see, okay fine, you can identify, okay fine, what is the difference in faces also. Suppose this is a feeding bottle, if you can see my cursor. So in feeding bottles we can wrap these kind of red tape. When child is able to feed, we can put torch. Suppose this is your bottle, over bottle you can keep torch and you have to feed like this. Then this is also, you are doing therapy while feeding your child, so this is a visual stimulation therapy. And even some of the time, if they are, toddlers and they are having eating, so I tell them to buy red color bowl, blue color bowl, orange color bowl, so child is able to recognize the color also. At home also I am saying, okay, choose the this bed sheet color, this should be your wall color, because you are having good visual acuity. But if your child is doing tummy time also, you need to place the, gray and black grating, so that child is able to perceive some amount of vision also. So if the child is toddler like 4 5 years, 3 years, then we can give tactile stimulation things also. We can place some rubber buttons, rubber handles over the child able to recognize. We can label the rooms to help navigate them, putting targets. Even if you see US, no, US, in US they are following so many things there to make CVI children's comfortable. In India, one and foremost thing is there, parents are not expecting accepting anything. Like if any child is autistic and you're saying your child is having autism, no no no, he's highly active but he don't have any autism. Then first of all we need to accept the problem of our child, then how we are going to treat the thing. Because even 3 days before also I've seen one child, and he just came and sit there over my chair when I am examining. The first day I was absent, he is not able to, he start crying, yelling, and anything. Mom is saying, "Ma'am, what happened with you? I don't understand. My child is sitting comfortably. I did refraction part, everything, shake hand, and even in doctor rooms also for the indirect ophthalmoscopy, he was very cooperative. And a day before, he was not cooperative at all. So what happened? Because first of all, when he entered my room, I told mother, okay, fine, he is having autism. Mother is saying, no, yeah, ma'am, mild autism is there, but it was severe autism. How you can identify? Because when you are keeping your practice like this, then you can identify, okay fine, this child may have this kind of problem. But how you are going to ask with the parents, it's a it's a task for you. So this is how we can identify the things in between. Then low vision aids also going to help the acquired CVI. So in this low vision, we are going to give magnifiers, and CVI can go school, CVI can do routine tasks also. Please make this clear, because there are some misconception also. CVI don't have a normal life. They are not going to give school. They have to go to the, special school also. No, they can go to the normal school. We can help them with the different type of tools, low vision devices, screen teachers. We need to provide them shadow teacher also some of the time. So we can do so much to change one lives. If you are changing one life, that's a, big thing for you. And orientation and mobility trainings also we are going to give, because they have simultagnosia problem, propagnosia problem. Then you are going to help them how they need to orient, because how they need to do in public place, how they need to do things in home. You have to identify, and slowly if you are teaching them, they are able to identify. Because some of the time what happens, if they see so much of people, crowd and clutter, they get confused, they feel, so they feel anxiety, they got panic. Then we have to identify, tell them how to identify, this is a part of their routine. Then they can, some of the time when they are honking something like bullet ka honk ho gaya, truck ka, they start crying. But slowly, gradually, you need to take them to the out, and you need to understand, okay, fine, my child will able to understand. And the peer group involvement is very important. So your child may feel safe and happy with the same peer groups, because few people are keeping their child inside, so they are more on screen, they are eating sweets, they are not interacting with the people, they are all the time on the phone. So these also is going to affect your child's brain also, brain neurons also. Then you should make them understand the peer group involvement is very important. You don't need to understand about the hygiene, your class and anything. Child is child, then you need to make a group and encourage them for the outdoor activity also. Then help them from a picture in their visual memory, because visual memory is a a task for a CVI child. Then suppose you are taking your parents picture and same in the photo frame, and then you have to tell the identification difference between the pictures also. This is how you can also use bright naturally occurring landmarks also, visual cues, help to orient the child from a route also. If you are taking them out, then you have to tell them anything. Use a tactile and the auditory cues also. If visuals are not good, then you have to use these two tools, which is going to help you more. Use descriptor to help the child understand what they are seeing. If they are seeing over, because suppose I have a child also, but I am telling what is this, then he is able to identify, okay mama, this is what. And this is, suppose if I am showing anybody on phone, anybody on screen, he is able to identify in screen also as well as in front also. Because that's took a lot of hard work and trainings also. It's just not we are going to deal with, you have to change someone's life and their daily routine also. This is a communication support and some areas also where we can do the task for they are going school and anything. All kind of communication except speech, work towards development or age appropriate social communication language skills. You need to talk. Suppose if your child is we are not talking about CVI. If your child is 6 month old, suppose Masi is at home, few of you are Chacha, Mama, anybody can be. So we are very excited to teach them. Say Mama, say Baba. Then you have to use vocal words together to make them identify. They can speech also. So in speech, you can help in this way also. Speech language, some of the time oromotor is not good. Then they need some speech therapy, oromotor therapies. Then you can refer them. And this is a management for the CVI counseling and the motivations also. The doctors play a vital role, give them hope. 50 to 80% brain deals with the vision in some way or the others. Early intervention will bring some improvement whatsoever. First 2 3 years of life are optimal for resolution of CVI. Recovery can go up to teenage. Okay, first you have to tell them this will take time, but your child is going to definitely improve. This is my responsibility, but you have to be patient, you have to work accordingly. How I am going to teach you, you need to stick with the treatment, you need to stick with the neurologist wherever you are referring, because CVI is a multidisciplinary approach. They need PT, physiotherapists, they need occupational therapists, they need speech therapists, they need optometrists, they need rehabilitation expert, because they can see with the object, because you are going to optimize, the contrast thing, field effect, glasses thing, and you can change so much of their visual field effects. You can prescribe prism also, you can identify, because environmental modification also done by the optometrist, so you are also a hero for them. So keep counting your blessings, because you are in this field. So I am keeping everything, like nothing is refraction. Beyond refraction, think, widen your views. Okay, you can do it, you can do it, you can do it. So don't limit your knowledge, don't limit your thinking, don't limit your anything. You are here to expand your knowledge, you are here to do so much. So do practicals, do anything. If you are looking any new thing, anything, then you have to discuss with your colleague, your juniors, your seniors, so you can understand and how we are going to help communities also. So one thing is also there, we need to motivate each others also. Suppose somebody is good in refraction, somebody good in clinical parts, then you need to support each others. That's how we are going to grow our community and helps together. So this is the integrated intervention with other therapies also. So here you can see, this is first picture is for the physiotherapy. So they are keeping supportive things and the posture thing. And here the special education, special educators are going to guide them and helping them to, treat their motor part as well as, and integrated therapy is going to help them to schooling and everything. And speech therapy, you can see, they all have to understand, because they are some of the time, if you see the CVI child and some CP child, cerebral palsy, so they are drooling all the time. So you need to some therapy, you need to incorporate in the child, like for the speech therapist you need to recommend. If you are going to give them a glass water, they are going to spill all around the table and everywhere. So you need to give them bottle, pipe, so many therapies are there. Sensory integration therapy provided by the occupational therapists aim to help children regulate, see, improves overall sensory processing skill, which can positively impact their visual function and all. If suppose if baby have a postural problem, you are doing so much, but you have to refer them to the physiotherapist also. Thank you so much for your attention, for your time, for your everything. Thank you so much.
Thank you very much, Rupali ma'am, for such a comprehensive session. Your structured explanation has helped us clearly understand how to approach CVI cases step by step. I think we should now move to the Q&A session. I request all the participants to post their questions in the chat box. Please keep your questions relevant to today's topic so we can make most of the today's session. Let's give it some time. Attendees, if you have any, okay, I think we have our first question. It is, have you tried syntonic therapy in CVI? If so, how is the effect of it?
No, I have not tried any syntonic therapy in CVI child, but yes, I have learned about this, because syntonics is going to work on wave therapy, so it's going to stimulate their particular integral part of brain, but it's not going to treat completely in CVI. But in terms of if we are talking about vision, then it is going to, yes, suppose if anybody's don't have vision and they are able to fix it, then syntonics is going to help them to improve their vision, but not much, because I have not done this and I am not aware about this. So I can say whatever I have read about it. So I think Dr. Kathy is also there, and she's experienced about syntonics. So ma'am can also share something about the
Yeah,
CVI.
more research is coming, and I do think it can have a big role in CVI. It's certainly not the only thing, but we're working on putting together right now some research. In probably the next 6 months, there's going to be a few articles we hope to publish, and then people will know more about how it can be used.
And
Okay.
thank you so much, ma'am. And I feel so blessed that you will become part of my presentation. And I feel so
You
happy
did
to
a
see
very
you
good
there,
job.
ma'am.
Thank you.
Thank you, ma'am.
Okay, I think
So,
that
any more
sounds it.
questions, Adya?
Yes, ma'am. We have another question by Arshad. Which assessment tool is most reliable for functional vision in infants?
Functional vision assessment, as we are saying, because vision contrast and everything comes under that. So Leah paddle for the vision assessment, and Leah wand, if we are saying as Leah wand, we are taking as a tool for judging the visual field discrimination in the children. And some of the time the contrast, hiding Heidi contrast card we are using to judge contrast in the CVI child. So accurately we have to do the diagnostic tools also. Some of the time we are checking with the the Leah wand also, Leah mail, Leah puzzles, and road cons, Leah, okay, all the equipments we can use to identify the functional vision in the CVI children's.
Okay, we have another question coming up. Is there any surgical treatment for CVI?
There is no any surgical treatment, but yes, if CVI is related to some secondary cause like hydrocephalus needs some type of fluid in brain, so they are performing VP shunt surgery to make it sorted, because of the hydrocephalus there is a multiple and the frequencies that this is going to affect child's brain also. And some of the time some they having some tumor problems, so they are removing, because we have to eliminate the secondary cause. But brain, if there is anything, if tumor is there, we can remove via surgery. But if brain is completely occipital parted damaged, then we cannot do it. But yes, as per the research, there is some stem cell implantation therapy is also going on. So almost abhi 27 28 patients almost done from the US to here. But few of them are going to improve their motor postures and skills, and few of them are same. So yes, the research is going on. But yes, if there is anything in brain and damages a visual cortex, visual ganglion cell, LG, and then we cannot treat. We have to treat the secondary cause.
Okay, okay. We have another question coming up regarding synoptic phototherapy. The question is, in synoptic phototherapy, they are giving different type of filters like alpha, delta, and mu delta. Why do they give these filters? What is the difference?
Because as I told you, because I have not any exposure to the therapy, whatever I have read about this, because as per the need of the child and what, like suppose in rehabilitation part also we are choosing the red target, yellow target. It depends, the recognition of child is better for which particular color. So that is why we are dealing with, and I hope they are putting the filter for a particular space and things.
Okay, okay, okay. Okay, we have another question. If the CVI child is looking constantly in the down gaze and whenever looked up, the child close his eyes, how to approach this case?
Can you please repeat your question?
Okay, okay. If the CVI child is looking constantly in the downward gaze and whenever the child looks up, he or she closes his or her eyes, how do we approach such case?
Okay, first of all, we need to see is there is any field effect, optic ataxia, or any another problem. When if their child is looking up and squeezing their eyes, some of the time that can be photophobia, and some of the time some allergic part also. So we have to examine the retina also, and we need to identify the field effect or whether it is optic ataxia. Then we need to treat accordingly.
Okay, okay. I think there are no more. Okay, fine. We have got another question. What is the best tool for using movements in different age group in child?
Okay, fine. What type of movement you are talking about? If there is a postural thing, then we are using so many things, like basically we are using rails to see if there is any movement, like they are walking over the pavements, any path, anything. So there is a we are, and some of the time we are just integrating the difficulty for the child, and if they are not able to move, then we are making hurdles pathway to see the movement and judgment for the orientation and the movement.
Okay. Have you used yoked prisms in CVI therapy?
Yeah, I have used in CVI, not exactly, but CVI I am using for the field defect only. If there is any nasal, temporal, inferior, and down defect. In autism, I've used yoke prism therapy, and they are quite helpful.
Okay, okay. We have a
And they are
question.
just collecting their attentiveness and their concentration and their fixation, their saccade pursuits improved a lot in autism, if I must say. In CVI, yes, there is an improvement in field, but in slowly CVI they are going to improve slowly. But in autism, 1 or 2 months after giving yoke prism, I have seen, a lot of change in their things like attention span, their attentiveness, their concentration, their activity participation. They improved a lot, and slowly gradually we are going to reduce the power of prisms also.
Okay, we have a next question, which is going to clear up a lot of doubts for our majority of the attendees. The question is, if the parent is not aware that the child has a CVI problem and is unable to give a proper history, then how can we proceed with a detailed clinical evaluation?
Okay, fine. So if the parents is not aware about the clinical history, suppose the delivery, the seizure, anything, so by the visual behavior you can judge the child may have CVI. Then you can request them for the MRI and the neuro opinion. So you are 100% sure this child is having. What you have to see when they are coming to you, you have to see, the child is looking straight in your eyes or they are like this. They are have some gazing issues also. If they are come up to your room or your clinics, they are looking up only. If you are saying anything, they are not going to respond for the light. They are not going to respond for the auditory things also. Then you can clue, okay, fine, there can be a CVI problem. Then you need to discuss with your senior as well as colleague wherever you are posted with the oftal also. Then you need to proceed accordingly, because MRI is going to help you to see what type of brain part and pathways damage there. Then neurologist is going to advise for them EEG also. Then EEG you are going to do the seizure activity. Suppose you are start treating them without any neuro intervention, this child is CVI. Then some of the child may have photoelectric seizure also, they are going to induce with the light only. Then you need to do EEG things also, and neuro intervention is must required in CVI. So that's how you can identify child may have CVI.
Okay, okay. We have a question about retinoscopy. If dynamic retinoscopy shows lag, do we have to give bifocal? If yes, what type of bifocal would you recommend?
Because as I told you, in CVI, because their brain is not able to understand what is there, how it is there, and where it is there. Then if you are going to do prescribe any bifocal, then how we are going to expect them to understand distance and near zone? As I told you earlier also, till the age of 3 or 4 years, till 3 years child having near zone, area only. So if you are getting lag, you have to prescribe the value you are giving in lab, but monofocal classes only, not the bifocal, until and unless child is motor and cognitively active. Then you have to prescribe only monovision glasses. What you can recommend them during the time of therapy, they need to use these glasses, because I told you earlier also, because plus is going to magnify the images and enlarge in the field also.
Okay. For CVI kids, can we do primitive reflexes?
Yes, they can have primitive reflexes.
Okay, okay, okay. Okay, Ria has again asked the question, what if parents are not agreeing the child has a problem? I think you have mentioned this in the presentation.
No, no, it's okay. I can answer here also. If suppose, Ria, if some child parents are come up to you, okay, and if we are taking our examples also, and some doctor is saying your child is having brain TB, then that's become very shocking for the parents. But slowly you have to make their for their understanding, you have to tell them, okay sir, at the age of 8 months child is able to follow and fixate, but your child is slowly moving and he's not responding that much. So what I am thinking, your child may have this problem sir, but you need you need to identify this, you need to go for a neurologist for this, and they can identify, okay fine, this problem is having. So I told you, Ria, for your better clarification, I have a case, and baby name is Aradhya, and they are also my parents till now. So I have seen this child in clinic, they are come up with the watering and discharge complaint only. Okay, so when I am doing Lia paddle, you are saying no, how we can identify? Everybody's cures. Okay, fine, how we can identify this child is having CVI? So if I am showing Lia paddle, because 6 month old child, if we are checking for better response, some of the time fixing was there. When I'm doing following thing, the from one gaze he is able to follow, another gaze total absent. So I was posted with the my senior doctor, Dr. Sovita. So I told ma'am, I feel there is something, there is some problem with the child. So ma'am is saying, तू सीबीआई करती है ना इसलिए तुझे लग रहा होगा उसको सीबीआई है. मैंने कहा नहीं मैम, इट्स नॉट लाइक दैट, आई फील देयर इज समथिंग. सो मैंने कहा मैम आई नीड टू डू वन एमआरआई एंड ईजी. मैम ने बोला ओके फाइन, फॉर योर थिंग वी आर गोइंग टू डू एमआरआई, कैन बी पुश इट फॉर 3 months later? No ma'am, we have to do it now only. So they go for the MRI test. Can you imagine, there is a occipital parietal lobe involvement with the secondary hypoxic injury in their brain. So that's how I identify that child is having, CVI. And that child start going school, sitting properly, everything. Because if we identify at the early age, CVI is going to improve much, much, much better. So parents are also coming with me for the regular flow follow up. Even I change my hospital also. So that's how you need to deal with the kids, because they come up for the watering and discharge only. तो दे आर सेइंग कि मैम आपने नहीं पकड़ा होता तो हमारे बच्चे के साथ पता नहीं क्या होता. So it's just like that, beta. You have to put attention, you have to be empathetic. You don't need to think about the money when you are dealing with the CVI child. So that is the purpose for your thing. And you need to be very empathetic also. Suppose if you are telling them, do this, you need to go to the therapy, you need to go for the integral education, and if they are not able to afford, so first of all you need to gain their confidence. Slowly you can incorporate all the things, slowly at a one go. If you'll refer OT, PT, speech, everything, then they get confused. So make a better and skilled approach. You need to gain attention, you need to gain concentration, you need to, gain the comfortability of the patient also. Then you have to understand their money things also. Accordingly you have to plan so many things. Few of them are coming to me, I am referring them to the government hospitals also, because we have to understand their socio economic condition also. So that is why.
Okay, ma'am. Now we have a real life based scenario kind of question. It is not a clinical question.
Okay.
Priya Hirani has asked this question. Ma'am, you said we need to counsel correctly, like it will take time and will get improved. This is our responsibility. Can we really
Yes.
say the word responsibility? And the parent is totally dependent on the therapist and expecting improvement and not getting it, then just coming to argue with us that we took responsibility for child to get improved. What to do in this situation?
Actually, I am practicing CVI for more than 6 years. I have never, seen these kind of things, because this is like unexceptional thing. Because if you are going to do anything head to toe, you are going to improve. If till 1 year, if there is a focus improvement, there is a mobility improvement, there is a postural improvement, out of 5 6 things you are going to improve one thing. So if parents is going to arguing you, then you can show them, okay sir, this is the condition, at this condition you came to me. Now you can see your child is able to sit properly, your child is able to see, your child is able to recognize, and you need to treat in that way. And that's I can 100% assure you, they are going to improve and they are going to get connected with you. Because I am living in Delhi, but my patients is from Bangladesh is coming. I told you this, I think before also. They are scared of getting and having second baby. On the basis of my counseling, they plan second baby, and the second baby is absolutely normal. So this is all up to you, how you are going to counsel your patient and the way you are going to communicate them. Because in normal OPDs also, if you are seeing 50 patient in a day, because I am doing comprehensive also, some of the patients are, coming and they are very upsetting mood, they all the time have the complaint, they have list of complaint. So you cannot do anything with these kind of patient, even in adults also. Leave the CVI part. So you have to deal with by your own. And yes, if you are dealing with the CVI patient, I think this is our responsibility to treat them, being not as a clinician but as a person. Suppose you are improving two cortical vision or cerebral impaired children and you are sending them to the school, it's give you another level of joy. And I feel that joy once my child start going school. So that is all up to you.
Okay, okay. That explains the role of the optometrist.
Hello.
Yes, hi Adnan.
Hello. Good afternoon, ma'am.
Good afternoon. Good afternoon.
Ma'am, first of all, I would like to thank you for managing this day for us. Also, we have
Thank
Dr.
you.
Kathy. I have a question or a short message want to be delivered or articulate by your way. May I?
Yes, 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 definitely.
In therapy like CVI or any vision therapy, when therapy is fundamentally like about neural connectivity or engagement and human interaction. It is a crucial part. So, ma'am, how far can online or AI based approaches truly replace the role of trained clinician presence, like observation and emotional connection with the child? Because people today, especially the youth of our generation, are like more impressed by AI based rather than home based or office based. So training requires human interaction also according to me. I want to please give this message too far for all who have joined today so that they can understand the value of human interaction. With increasing use of online tools like digital aids, what limitations do you see in managing CVI without direct human interaction, basically?
So suppose as per my practice, even in AI era also, AI is not going to understand your emotion first of all, and you have to way better. You are going to connect with the patient. Suppose AI is going to we are going to generate some software, okay, and we are going to give some beautiful commandable robotic like things, but that things are not going to understand your emotion, your pain, your anything. But the thing is, suppose if your AI is built up in a software, the software can give auditory command, that's definitely audible become better. But if your child is having posture problem, your child is not able, you have to motor problem, cognitive skill development problem, and there is a cerebral palsy, so there is a multiple motor disorders and multiple problem, then how AI going to treat? No, you have to be empathetic. Physiotherapist will required, and your rehabilitation will require, does not matter. AI cannot replace the human, I think, in my way also, because in terms of technology, software advancement, and cognitive skills development, vision stimulation development, because these all are digital devices thing. But the emotion, but one to one connection, and the the connectivity with the patient, only the human can play a role, okay. Because I'll just give you an example. People is having redness nowadays. What happened? They start googling over the medicine for the redness. So if there is a predfort is a solution for the redness with the discharge, so do you think they have to go for the prednisolone rather than putting moxisip and refreshed here? So AI is going to give you a route way, okay, not a pura complete roadmap. You have to do it in that way. So AI is helping you, but of course, definitely there should, CVI is a field where connectivity and connection literally matters from my end. But yes, if anything, then Kathy ma'am, please add on some.
Sorry, I didn't have a very good connection there for a few minutes.
Yeah, Adnan, can you repeat your question to ma'am?
Hello.
Yes.
Yeah, so ma'am, I asked like human interaction is very crucial when it comes to therapy. Not only the AI based therapy, which is like only to give computer based applications. Child is like to recognize, to be feel empathetic, to connect, to rearrange the things. So human interaction is also play a very important role. So I asked ma'am like with increasing use of online tools and digital aids, what limitation do she see in managing CVI without direct human interaction?
So I think for a lot of things, we think AI is going to take our place, but I don't really believe it is. I think
Yes,
it can give us guidance. I think it can put a lot of information together, and by putting that together, we may see a pattern that we wouldn't see without it. But I think that all children learn from human interaction, and they learn from the concrete to the abstract. And so they need that level of treatment, both in terms of the toys and things that you use in your therapy. They need it in terms of the things that parents do with them. I see now when I walk around everywhere, young children that are on screens, they're sitting in a stroller looking at a phone or a tablet. That's not how the world is supposed to be, and that's not how children learn.
Yeah, ma'am. Thank you. Thank you for this beautifully addressing my question.
So yes, everybody's doubt is, I hope, clear. So
No,
AI cannot replace you. It is
yes,
going
ma'am.
to give you a clue, roadmap, but nobody can going to replace you. But you have to be stick on with your skills, with your emptiness, with your, empathetic part, and your compassion and dedication required everything. So yes.
And before we end the session, ma'am, there is another question. This is slightly out of the topic for today's session.
Mm.
Can you still take it? Because
Yeah,
it
yeah,
is
yeah.
quite interesting.
No problem.
Okay, okay. So Ziauddin has asked, how can a drop absorb through the cornea and block the alpha cells who produce more aqueous humor in open-angle glaucoma?
What?
How can a drop absorb through the cornea and block the alpha cells who produce more aqueous humor in open-angle glaucoma?
I think this is out of syllabus, definitely. But who is the guy who is asking for the question? I want to interact with the person.
Yeah, I think let's facilitate this. Ziauddin, unmute your mic and ask the question directly.
मैम आई एम कंफर्टेबल इन हिंदी.
Yes,
Okay,
yes, you
please.
can.
Go ahead.
मैम मैं पूछना चाह रहा था कि जो हमारी कॉर्निया है, तो कोई भी जो आई ड्रॉप है वो थ्रू द कॉर्निया जा करके चीज़ें सही नहीं करती है.
Hmm.
तो जब हम लोग टिमोलॉल या ऐसी कोई बीटा ब्लॉकर या अल्फा ब्लॉकर ड्रॉप डालते हैं,
Hmm.
तो मैम वो बीटा सेल्स या अल्फा सेल्स को जा करके कैसे स्टिमुलेट करती है और उनका एक्वस का प्रोडक्शन कम करती है.
Hmm. So, I have, similar question asked by one of my junior also. So, ma'am, how? But the thing was different. उसने मुझसे पूछा, मैं भी आपके क्वेश्चन का जवाब हिंदी में ही दूंगी. उसने पूछा कि मैम, जो ये बीटा ब्लॉकर्स होते हैं, ये जाके हमारे उसमें ड्राइनेस कैसे कॉज करते हैं? बिकॉज वेन एवर, जब भी हम कोई भी आई ड्रॉप डालते हैं आँख के अंदर, ठीक है, so there is a cul-de-sac and a few amount of the eye drop is going to absorb by the conjunctiva and the cornea also. But जो timolol and जो आपके एंटी ग्लोकोमा मेडिसिन है, आपका क्वेश्चन यही है ना कि वो बीटा ब्लॉकर्स कॉर्निया से तो जाते नहीं है, वो कैसे काम करते हैं, आप यही बोल रहे हो ना?
जी मैम.
तो अगर हम लोग जब छोटे थे तो साइंस में हमने ऑस्मोटिक और ऑस्मोसिस प्रेशर पढ़ा था. सो देयर इज अ सेमी परमिएबल मेम्ब्रेन, ठीक है, तो वो जो
यस मैम.
काम है वो हमारा कॉर्निया करती है, जिसके थ्रू वो ड्रग रूट के थ्रू हमारे उसमें पहुंचते हैं सिस्टम में. और जो बीटा ब्लॉकर्स है वो हमारा एड्रेनलिन होता है और उसके दो रिसेप्टर्स होते हैं, मस्करेनिक और एंटी मस्करेनिक रिसेप्टर्स, ठीक है, जो कि मिमिक करता है उसके एक्शन को एड्रेनलिन के, जिसकी वजह से वो वहां जाके काम करते हैं. और जो हमारा एक्वस है, एक्वस की जो हमारा क्लोजर एंगल क्लोजर ग्लोकोमा है, उसमें क्या है कि जो हमारा ड्रेनेज पाथवे है वो ब्लॉक हो गया है, ठीक है, तो वो उसको जो भी हमारे स्लेरी मसल्स के जो लेंस के जन्यूल्स होते हैं उन्हें रिलैक्स और कॉन्स्ट्रिक्ट करता है एज पर आवर चॉइस ऑफ ड्रग, हम उसको क्या दे रहे हैं. और देन दूसरा जो एंगल हमारा ओपन है वो उसको जाके क्योर करता है, ठीक है, और एक्वस फ्लो को मेंटेन करता है अकॉर्डिंगली, ड्यू टू जो हमारा ऑस्मोसिस जो हमारा चीज है, जो एक परमिएबल मेम्ब्रेन होती है जिसके थ्रू हमारे जो सारे ड्रग्स होते हैं या जो भी रूट होते हैं हमारे उसके थ्रू ही डिलीवर होते हैं. बिकॉज कॉर्निया इज अ ट्रांसपेरेंट सरफेस, है ना, जब भी हम उस पे कोई चीज डालेंगे तो वो क्या होगा, वापस आएगा. बट देर इज अ सिस्टम, देर इज अ केनाल एंड देर इज अ पाथवे, जिसके थ्रू वो जो चॉइस ऑफ ड्रग है वो वहां पर जाके इफेक्ट करता है, क्योंकि उसके अंदर ऐसा सब्स्टिट्यूट बनाया गया है कि वो काले मोतिये की जो हमारा जो एंगल्स है उसके पर्टिकुलर एरिया पे जाके काम कर सके.
I think that answers your question, Ziauddin.
Ziauddin, any other thing you have to ask?
नो मैम।
बिकॉज जब भी हम कोई भी ड्रॉप डालते हैं तो वो कॉर्नियल एपिथीलियम के थ्रू ही पेनिट्रेट होता है और रास्तों को, अगर हमारा डायरेक्टली कॉर्निया के थ्रू नहीं जाता बट उसके बाद कॉर्नियल एपिथीलियम है, स्ट्रोमल लेयर है, एंडोथीलियल है, देन उसके बाद वो एक्वस ह्यूमर से एक्वस ह्यूमर के पास तक पहुंचता है। तो जब भी हम डालते हैं हमें लगता है हमने तो ड्रॉप यहाँ डाला कल्डी सेक में, बट वो काम ऐसे ही करता है।
Mm-hmm.
और जो
Okay.
कॉर्नियल एपिथीलियम लेयर होती है वो मेन बैरियर होता है, तो उसी के थ्रू जो हमारे जितने भी ड्रग्स होते हैं वो अच्छे से एब्जॉर्ब होते हैं और वो उसी रूट के थ्रू, यही हमारा पाथवे है और पहुंचते हैं वहां पर। और कुछ पूछना है आपको? अगर
जी
पूछना है
मैम,
तो यू फील फ्री एंड यू कैन आस्क।
मैंने पढ़ा था कि मतलब कॉर्निया जो है वो लिपोफिलिक लेयर होती है, तो इसलिए
हम्म
कोई भी ड्रग क्या कहते हैं उसके थ्रू नहीं जा सकती। जैसे
हम्म
फ्लोरोसिस हम लोग डालते हैं तो अल्सर
हम्म
के टाइम पे,
हम्म
तो मैम वो अंदर एब्जॉर्ब नहीं होती, वो उस पे सरफेस पे ही रहती है।
हम्म। लेकिन
इसलिए
आप
मैंने
ये
क्वेश्चन
सोचो कि
पूछा।
अगर वो सरफेस पे है तो वो काम कैसे करेगी? वो लाइपोफिलिक इन नेचर है, बट एपिथेलियम क्या करती है, रिस्ट्रिक्ट करती है हाइड्रोफिलिक कंपाउंड्स को, बाकी जो कंपाउंड्स है वो अलाउ करती है जाने के लिए। वरना आप सोचो कि जो इंट्राऑक्यूलर प्रेशर है या हमारे को कोई भी कॉर्नियल, सपोज हम नॉर्मल कंजंक्टिवाइटिस है या नॉर्मल किसी पेशेंट को एलर्जी है, तो वो कैसे ट्रीट करेगा फिर?
आंसर करो जियाउद्दीन।
जी मैम।
क्योंकि ये हमारा कॉर्नियल एंड नॉन कॉर्नियल रूट्स दोनों फॉलो करती है, ठीक है? तो अगर हमारा वो नेचर है उसका, वो तो रिपेलेंट करेगी, बट उसके अलावा वी हैव 5-6 मोर लेयर्स जो कि उसको काम करेंगी। और अगर सपोज अगर आपने पढ़ा है तो अगर हम उसके थ्रू अगर वो एब्जॉर्ब नहीं होगी मेडिसिन, तो फिर वो कहाँ से जाएगी? फिर तो उसका इफेक्ट ही नहीं होगा, बिकॉज पाथवे जो मेडिसिन का है वो ऐसे ही प्रोवाइड होता है, ठीक है? तो जो कॉर्नियल एपिथेलियम है वो एज अ बैरियर काम करती है।
ओके, थैंक यू मैम।
Okay, okay. Okay, thank you so much, Rupali ma'am. On behalf of Neuroptic and all the attendees, I sincerely appreciate your time, effort, and dedication to optometry education. We're truly grateful for your contribution today. I would also like to acknowledge and thank Asaduddin, our founder and co-founder, and Arman, our administrator, for their continuous support in organizing and managing these sessions. Their efforts behind the scenes make initiatives like this possible. I hope by the time it will be done. Thank you once again, Dr. Rupali, and thank you all the attendees for joining us today.